Hello, good afternoon. It's my pleasure to be back here speaking to you. And this time we're going to speak about patient-reported outcomes. What are patient-reported outcomes? And do they matter? And should we be bothering about them? If so, how? Who's going to be my timekeeper? Tiro did a great job before. Can you tell me when it's 5 minutes, please? Right. I became interested in patient-reported outcomes many years ago when the ophthalmic oncology group, Yvonne Brandberg from Stockholm, Stefan Sterregard, myself, and one or two others got together, and we designed this questionnaire looking at symptoms after treatment of ocular tumors, pain, discharge, visual problems, fears about recurrence, fears about metastasis, things like that. And we've been using it ever since. I've been using it ever since in Liverpool, and now I'm introducing this into UCSF. And here's an example of what you can get on 2,000 patients as one of the questions from this questionnaire on whether activities were limited by poor vision. And you can see that after enucleation, these patients are more likely to report difficulty with visual function. But there's a lot there that behind the scenes. It all depends on the results of radiotherapy as well, whether the patients can see after radiotherapy or not. All depends on how long after the radiotherapy this has happened. And then there's a lot of psychological overlay. It depends on the age, gender of the patient, social factors. It's not as simple as just asking a question like this, and you'll see why later on. Here's a fear of metastatic death according to genetic tumor type. If they're monosomy 3, of course, they're more afraid of metastatic death, especially as some of those might already have symptoms from metastasis at the time when they completed their questionnaire. What's surprising is that those patients with disomy 3 and a good prognosis had there was a significant number of those who were afraid of metastasis. So obviously we're not counseling them well enough. We should. I was surprised to find out that there was this problem. But Laura Hope Stone did a study to show that uncertainty and fear of metastasis is a very complicated thing, and if you solve one problem, the patients become anxious about something else, and if you solve that, they become anxious about something else. It's a complex situation. Well, this shows the quality of life after enucleation as compared to radiotherapy, and it looks very much the same. And if you see the patients with the poor quality of life, if we ask them if it was due to their eye or due to something else, only in about 12% was the poor quality of life due to their ocular disease. In many patients, they had a bereavement, they had lost a wife, or their husband, or a brother or sister had died the previous few months. So it's really important to consider other factors as well. And this shows quality of life according to social support. Those patients who, when they completed the questionnaire, who said that they had somebody to speak to, somebody who hugged them, all that kind of thing, had a much better quality of life than those who didn't. And these factors seem to be much more influential than the actual treatment we give to them. So they must be taken into account when looking at patient-reported outcomes. The Ocular Melanoma Foundation in the United States recently conducted a questionnaire, and there's a study that's in preparation on patient-centered outcomes, where the patients perform the research and we help them to do it. And they design the questionnaires, they choose the questions, and all of that. And these are the things they're interested in, whether they received psychological counseling, whether it was good, well done or not. If they want to have questions about the way information is given, whether they're given information about speaking to their children about their cancer, about how to speak to their family about their cancer, and so on. And so what the patients want is to have this kind of information at their disposal. So they have a TripAdvisor about ocular oncology services, and they know that if they go to one oncologist, he or she will speak to them and give them psychological support. if they go somewhere else, they're not told anything about any other treatments other than one kind of treatment. If they go somewhere else, there's a deficiency there. And that's what's happening, that's what's going to happen. And this is patient-reported outcomes driven by patients. So the situation is changing. Patients are becoming much more involved, much more savvy, much more information. They know much more about this than they used to, thanks to the internet and their collaborations. And we are going to become more and more involved in this. So I'd like to acknowledge my colleagues in Liverpool and the United States. And now it's my pleasure to introduce the next speaker, Laura Hope Stone, a psychologist in Liverpool. We are very lucky to have a full-time psychologist for ocular oncology, doing nothing else but looking after the tumor patients, eye tumor patients, and that has made an enormous difference to our service and to the patient satisfaction. And it's a spin-off from the quality of life questionnaires that we started using many years ago. Thank you very much for coming from England for this.
Hello, so thank you, Prof. D'Amato, for inviting me to speak today, and Dr. Paul Finger as well. My name's Laura Hopestone. I'm a health psychologist at Liverpool Ocular Oncology Centre. And I'm going to talk to you a little bit about some of the results we've got from looking at quality of life in our patients. So at Liverpool, every patient that's been diagnosed with intraocular melanoma is invited to participate. And if they consent, they're sent paper questionnaires at 6 months, 12 months, and then annually thereafter. The responses are then entered onto our Luke database, which is exported and cleaned and prepared for analysis. And this is no mean undertaking. We've had to develop a macro to deal with longitudinal data, and it's taken quite some time to prepare it, so we can actually get something we can look at, and I need to acknowledge Nicola Longrig for that. So the questionnaire comprises of socio-demographic details. We looked at the global health and quality of life in relation to the eye, and that's what Professor D'Amato has just mentioned. We also use the EORTC OPT30, where it looks at visual impairment, ocular irritation, appearance, worry about recurrence, reading, headache, and functional problems. Quality of life, we use the functional assessment of cancer therapy, which is a well-known tool used throughout many different cancers. For the mood, a very long-standing, well-validated one, hospital anxiety and depression scale. We also have some measures of social support. And we can merge these with clinical data, for example, treatment type, age and gender. So I'm going to report on just some findings that we've had from looking prospectively over 2 years at mood and quality of life, which we compared with normal populations. And we also tested the association of outcome with gender, age, and treatment by enucleation. So participants were treated between 2008 and 2011. And what we did is we took descriptive data for both mood and quality of life and compared these at each time point using independent t-tests. And the time points were 6 months, 1 year, and 2 years. So anxiety and depression was compared to samples from Germany, Sweden, and Netherlands, and quality of life with the US, Australia, and Austria. And we also, as I said, tested the outcome with gender, age, and enucleation. So we had 418 patients in this particular cohort, reasonably evenly split between males and females. Median age at treatment was 64. About a third were enucleated, and 2/3 had their eye preserved. So this is anxiety. This is anxiety in males and females at each time point, and we can see that our patients at each time point were, on the whole, more anxious than the normal populations, all bar one, which is this Dutch study here. We split that by males and females. We can see that there was no difference with the males, but it was the females that were more anxious, again, compared to the two normative populations. Looked at depression, and in this case, our patients overall were less depressed than the normal populations. And split again, our patients again were less depressed. This is the quality of life, overall quality of life. And again, these patients, it's a higher score is better quality of life. So these patients had better quality of life than the comparative populations. Slightly mixed picture for the males and females. But overall, both quality of life and depression were either superior or similar than the normal populations. But what we did find is that females were more anxious than the normal population. And when we did further testing, it was the younger female patients which were more anxious overall. What we did also find, as Professor D'Amato has also alluded to, is that enucleation was not associated with an outcome. So the research implications are, so we need to be able to identify more factors that may predict psychological vulnerability. And we can also add additional problems, for example, phantom eye syndrome, symptoms of that. We found that mood and depression is associated with those symptoms. We want to see what the direction of that effect is. Also helps us to tell patients how they might feel over time. We also need to alert clinicians, patients potentially needing extra support, and we need to develop psychological interventions for the minority of patients who require specialised help.
Thank you.
And I'll just conclude that, really. And thank you.
Thank you very much. To be honest, I didn't believe Laura when she said that the quality of life of our patients is better than that of the general population. But apparently this happens with other cancers as well, isn't that right? So next, Andrea Villaroman is going to... Is it? No, it's Tara McCannell. Sorry. Who is it? Colin is going to speak. Yeah, Dr. McCannell is going to speak about the LA experience.
First off, also I want to extend my gratitude to Bertel and Paul Finger for having me as part of the meeting, and my wife, of course, and it's just a wonderful meeting. We're going to be talking about patient-centered or patient-reported outcomes, and it's a complex topic because it measures something that is highly subjective, possibly changing, and dynamic over time throughout the treatment and following the treatment. At UCLA, we've sort of taken an approach to sort of try and deconstruct this to then have a better approach in addressing how we can improve the patient-reported outcomes. First of all, patients have a difficult time assessing whether they've had good care, and the patient-reported outcomes include the perception of the quality of care, and that is due to lack of knowledge. They don't know what's supposed to be happening. They trust their doctor and assume that the best is going to happen to them. And also, it's a singular experience, so they can compare it. They can compare 3 different coffee shops and have their favorite one, but when it comes to cancer treatment, they will have one treatment, and they will have no comparison. And also, poor outcomes don't necessarily mean poor care, and that is something some patients understand better than other patients. And obviously, in ocular oncology, poor vision outcomes are one of the problems. So the first 2 parts of this is then there's the subjective experience, and then the second part is the objective outcomes. With regard to the subjective experience, the factors that influence that is the perceived face-to-face time, things as unimportant to outcomes in our mind as wait times in the waiting room, or convenience of parking, the courtesy of the staff, and the amount of pain associated with the treatment. Some patients say, "Oh, you're the best doctor. My surgery didn't hurt at all." Things like that. And these factors may affect the impression of the quality of care, because those are things that the patients can judge. And they will also judge their outcome based on these kinds of perceptions. Now, in contrast, the objective parts are very, very black and white, and those are the kind of things we're used to measuring: survival, loss of vision, loss of eye. And with education, the patients can understand them, and they may also affect the quality of care. However, poor outcomes may be attributed to the disease itself and not to the quality of care, and have a different impact than we would expect on the patient's psyche and perception of quality. However, better than expected outcomes may have a positive impact on the patient's quality of life because they feel good that they had such a great treatment, and therefore a positive impact on the patient-reported outcomes. So affecting the perception of patients, the subjective experience can be addressed by addressing all the factors that go into the subjective experience as best as one can to provide then a better overall feeling for the patient of having received good care that then leads to good patient-reported outcomes. On the objective side, we can certainly, perhaps most importantly of all of these things, is manage the expectations so that the bar is set appropriately so that even a poor vision outcome with a successful treatment doesn't lead the patient to believe that the poor vision outcome is because of poor care, and therefore it becomes quite acceptable because they can focus on the survival and not on the vision decline from the treatment. And then, of course, aim to achieve the best possible outcomes.
So we've been thinking a little bit about patient-reported outcomes, especially with this topic and this being a growing issue. And one of the things that we are trying to work on are sort of focusing on both the subjective aspects as well as the objective aspects. So, for example, objective things, what can we do to improve the vision? Because that's something that is objectifiable and we can measure that. You know, at our center, we're doing treatments to focus on best vision, as everybody is in their center. And one of the things that we're doing at our center is using silicone oil. You put it in the eye, it actually blocks radiation and can reduce the radiation side effects. Just a schematic of filling the vitreous cavity. The subjective experience can be altered with efforts to enhance the patient's overall experience. So routine prognostic testing, something that many of us do, that can also help to manage expectations of the patient and allow them to feel that they are very much a part of their care and information is important. So some of the other subjective things that patients have a reaction to is, how was I treated? So we need to think about, what is their experience? Were the staff courteous? Were they seen in a timely manner? Were the staff in the operating room friendly to the patient? This is very important to affect their perspective. Were they treated with respect? If they were waiting for a long time, did someone come and tell them that the doctor will be another 20 minutes, or give them something to understand why they're in the clinic for a long time? And certainly when a patient calls with questions or they need a prescription filled, was there timeliness? And all these things are important to address, and we certainly think of these things when we're thinking of the subjective experience. Did I get answers? Did I feel like I was part of the discussion when a treatment was recommended to me? Did somebody in the office connect with me and come up with a plan so that we could treat this problem together? And it's very important that these things be considered, because oftentimes patients feel alone, they don't understand the information, and it's very important not to make them feel lost. So the question, was the treatment a success? Well, many times we think about, do I have metastatic disease? And no, you don't have metastatic disease, so a patient may feel that this is good news because the treatment has been successful. So this is a positive reported outcome. However, if there is metastatic disease, we might think that the patient would feel that the treatment doesn't help them. And this could be viewed as negative, but also it can also be positive because the patient was very much involved in all aspects of their treatment and care. And just a few things about what we can do to help alter some of these things and help set expectations. You know, the patient is coming to an oncology center, they may be diagnosed with cancer. These are sort of obvious things, but I think we need to be very apparent, let patients know that they may be there for several hours if there's extensive testing. And certainly let the patient know that the treatment or the cancer itself can cause them to lose their vision, and we'll hope for the best and see what the patient eventually sees. Our institution has a questionnaire that is sent out to all divisions and departments of medicine. However, it is not specific to ophthalmology, and we run into problems with this because the wait times in many other disciplines are very short, and ophthalmology, especially when there's dilation and additional testing, can be very long. So there's no oncology-specific context, but oftentimes the free text is helpful. And again, many times our own perception that we see in our practice with patient-reported outcomes is what's said to the doctor directly rather than in a formalized manner. Many patients don't voice the concerns that happen, and only the ones that are vocal tend to share their opinion, and we need a more uniform approach. So things that we focus on try to retain the eye. We try to limit enucleation using biopsy and using measures to help improve the vision. These are going to help our objective findings. So just to summarize, I think patient-reported outcomes go beyond what we traditionally understand about quality. We might need to redirect clinical management to help focusing on the needs that may influence the whole patient, such as giving information about prognosis. And we need to have efforts that explore factors that might alter patients' perceptions. Thank you very much.
Now it's a pleasure to welcome Andrea Villerman, who's a research assistant in ocular oncology at UCSF. And for the past year, she's been working on patient-reported outcomes and has come all the way from there to give this talk. Thank you very much.
How do I control? Okay. Good afternoon, everyone. I'm pleased to be here. My name is Andrea. I joined Dr. D'Amato's team in late 2014. And since then, I now firmly believe what Dr. D'Amato has been advocating for several years already since he was in Liverpool, that patient-reported outcomes need to be an essential part of clinical care. And one way to address that is what I've been working on for the past several months. The goal of the work for these past several months was to find a way to collect and measure patient-reported outcomes and merge them with clinical features and outcomes. And at UCSF, we did this by merging two platforms. Number one, EPIC. If you're all familiar, it's UCSF's electronic health record system that is used widely among other major research institutions in the United States. And a third-party platform called VisionTree, which is an in-browser platform that specializes in patient-reported outcomes. And it's been around for a decade or so, and they're also certified for meaningful use. So the technical work we did on this side was to create a list of PRO questionnaires that we worked with our co-PI, Dr. Laura Dunn, a psychologist, for an IRB-approved study so that we could start working on this project. And then we created a set of clinical forms in VisionTree that would match up with data that are entered in UCSF's customized version of EPIC called APEX. And how did we do this? Well, we created a set of customized flow sheets with our electronic health record system called documentation flow sheets. And this is a tabular set of data this is a tabular form that providers enter data into that gets sent into the clinical forms in VisionTree so that it can all be in one space. And in the end, all of this goes to data exports, and you can analyze it in the data analysis software of your choice. Now, I do want to touch on something that we've touched on earlier today with doctor-reported outcomes, and that is that during the design phase of this, we really actually were starting from square one. And when we were designing our database, we had to really start working on creating discrete data elements for CROs and for PROs. So this is just an example of a template we used. You need to reduce free text. You need to have unique code names for all of your data fields. You need to know your question fields and the exact responses that you're going to have. And if you're going to have special case responses like other responses, you need to create other fields for that as well. And this is just an example of what the tabular form of the data entry looks like. I'm going to breeze through these because I don't have a lot of time, and this was a lot of work. We had to establish a close relationship with our EHR team, and it looks daunting, but as we evolve our system and data dictionaries, this could potentially be a very easy thing to integrate into other systems because it becomes standardized over time. On the PRO side, if anyone's interested, we can demo this offline. But this is what our platform looks like in browser. And this is the list of PRO forms we have for the specific IRB study we had titled Patient-Reported Outcomes in Patients Who Have Been Treated with Eye Cancer. And As you can see, Vision Tree has this platform here, and the nice thing about Vision Tree is that it has a master list of stock PRO forms and CRO forms, but we were also able to customize forms specifically for ocular oncology. But we don't want it to be different for everyone. And in the grand scheme of things, we really just need to bring a standardized set of PRO forms that become a part of clinical care. And I have a few design considerations, but we can breeze through that. We just went live last month, so I have a few results for you. We have a ballpark amount of 35 patients who have used this site, and it's important for us to get end user feedback because it's the patients we are really targeting and the patients who are experiencing the site. So this was our recruitment process, and they get automated emails sent to them to fill in the forms if they're not in clinic, to fill in patient-reported forms. We created a usability survey to really understand how the patient was using if they enjoyed the experience of the patient-reported outcomes platform. And we got fairly positive feedback for ease of use, as well as a few suggestions that we can work towards. One thing I remember distinctly while I was working on this project was a conversation I had with a patient, and she told me after taking the surveys, I don't always get the opportunity to talk about how losing my vision is affecting my life. And I think that really speaks to the need to integrate all of this into clinical care. And we are hopeful, but to step out of the research space and into the clinical space, there are so many barriers, and we're hopeful that during this working session, I have to skip through this, we can have a discussion to help us break through and find a way to really make this part of our clinical practice. Thank you.
Thank you very much, Andrea. Now it's a pleasure to welcome Tara McCannon again, who's going to speak about the future.
Because I can tell you exactly what's going to happen. So I think we've all heard some very important things about patient-reported outcomes, and I think Andrea and Dr. D'Amato and your site, there's been quite a lot of development, and I think we can certainly learn from that. And so some of the things that I thought, first of all, let me move along here. One of the things that we might want to have everybody come to an understanding is, what is the definition of patient-reported outcome, and is it as clear as we think it is what the patients are saying, or are there certain criteria or aspects that are important for patients? So, you mentioned merging CROs with PROs. That's sort of what I'm thinking that is very important, is that we need to sort of align what we may be evaluated by our governing bodies for healthcare, especially in the United States, and this is going to be very important because patients may be the ones, and their experience is going to drive how we can practice medicine. And I think, this is probably in some of the work that you've already done, but looking at how are we going to break down the definition? Is it going to come into some of it's going to be the experience the patient had, just basic things like comfort, vision, and of course variables that affect quality of life. We might think of, again, probably have some kind of scales, a numeric scale that we can get the data from, and this would be important to sort of get a more objective way to analyze the data, and so assign a number or score to a person's experience. That way we can compare one patient's experience with another, and also compare experiences overall at different centers. And I think part of the mission of the working group is how can we improve what we're doing as individuals and come together and do something that is far superior. So I think this next step of analyzing what the specific patient outcomes are and then comparing them between centers is important. And I think also it's important as a group to think about what are the causes for some of the scores. For example, if one center has a lot of dry eye, and for example, a patient undergoes proton beam, perhaps another center may say, well, I also do proton beam therapy and we do routine punctal plugs at X number of months. I mean, something I imagine, but that might be something that one center could learn because they have a different score. I mean, it sounds very simple, but doing these exercises could help us easily change what we do for improved patient outcome. And certainly, instituting the change once we've learned some of these things from our colleagues and the experience of others obviously plays into this, because this is something that we would learn from each other. And another example that since this is a very new area, certainly to me, for example, a patient, if there was a reported outcome of a lot of diplopia for resection of iris lesions, perhaps a center who manages these with radiotherapy might have less of this. So this could be another example where one center might consider making a change with how they manage a condition in order to help improve patient outcomes. And certainly I think it's very important that once we make changes, we go back and reevaluate, we rescore and see how we can improve. But I think that these are some of my thoughts, and perhaps as came up in previous presentations, having a website to help log results so people could see how they compare, and maybe there could be some anonymity to that, and perhaps have subgroups and individuals responsible for specific aspects to help monitor and help manage this so we can move forward. So I open the floor and welcome your suggestions and ideas on this topic. Thank you.
Thank you very much, Tara.
Thank you.
Do you want to stay and
Sure.
address the questions together? Brenda? Dr. Galley from Toronto?
Could I just ask how this relates to stress reporting by patients, which is pretty embedded, certainly at Princess Margaret, and Tran could speak to the tools that she's built for stress reporting, patient-reported stress factors. Is that a common thing in the U.S.?
I don't know what happens around the U.S. I don't even know what happens around England. I just know what happens where I work, and that's why Tara's come, to speak about a different perspective. But the best person to answer would be Laura, who's the health psychologist, and she will mention. Do you have a microphone? Can you have? Laura will speak about the psychological instruments that are used to. Yeah.
Hi, I'm Tran from Toronto. So we've been working with a distress assessment response tool at Princess Margaret for a couple of years now, which incorporates PROS. And we do have things to measure anxiety, fatigue, and we're currently adding pain and depression. So we actually have a system. It's a web-based system that is in all our clinics, and we have iPads that are set up. And so every patient that comes in, it's actually mandated that every patient complete these surveys. So we do have, probably 250,000 surveys that we do have data on. So I think it'd be very interesting to look at, the data that we're collecting in the eye clinic and sort of look at correlation to some of the data that you've been collecting.
I think that's really essential, because if you ask patients in the clinic, how are you doing, they all say fine. And if you ask them to complete a short questionnaire, you'll see that they're very worried about metastasis and they've got all sorts of other things that they just wouldn't mention to you if they didn't have to fill in a short form.
It's a very interesting topic. I have a question. Sorry if I missed it in the talks, and it's related to this comment. It's one thing to sort of start developing tools and validating them ourselves, but I'd be interested to hear more about how existing scales may have been incorporated into these tools that are being developed. There's, the mental adjustment to cancer scale, hospital anxiety and depression scale. I wonder if those are useful in this context or if we're just making something new for some reason.
Do you want to answer that?
I don't really have the. We're not working with specific. We've developed our own scales in previous research, and we haven't used standard VFQ scales. And you may have a similar experience.
Right. In Liverpool, we use the HAD score, FACT-G, which are widely used in oncology and other diseases. In San Francisco, we're using the PROMIS and FACT-G and fear of recurrence. Every psychologist seems to have their own pet off-the-shelf instruments, which they like, depending on what their main interest is. Yes. Did you want to say anything, Andrea?
I think if the group is going to move forward with this, I think it's important to create subcategories of patient-reported outcome measures. So the EORTC work that you've done, I think, is an excellent measure for clinical trials. And then we're talking about real-time assessments of patients coming through the clinic. Those are all different questionnaires, different goals, different lengths, different constructs are going to be involved. And so I think it hasn't been mentioned yet, but those are, I think, the first step is to realize what goals do we have, and then we should formulate specific questionnaires depending on the various goals. We built up on your work the last 3 years. We've been developing a real-time questionnaire to be used in clinic in real time, similar to how the Toronto group does, but specific for eye patients with melanoma. And that's going to answer one question in the whole scheme of things, and all the other work. It's going to all have a slightly different approach and a different information it provides.
Yeah, it's really useful to have the patients complete questionnaires when they come to the clinic, but it's also useful for them to complete questionnaires after 6 months, on the anniversary of their treatment, for many years, and so on. Not only for us to be able to advise future patients, not only about the chances of losing the eye, but how they will actually feel if they were to lose the eye, or how they would feel if they were to have a recurrence. And also to be able to counsel individual patients, to predict, to identify which patients are most likely to develop certain psychological problems. But in Liverpool, Nicola Longrig every month sent out more than 100 questionnaires, isn't that right? And then had to send reminders, and then had to computerize everything. She's still doing that. It's a very, very labor-intensive process, and she's very, very good at it. The approach that we're following in the United States is the automated version, whereby patients automatically get emails and reminders if they don't complete the form online, at home, using their iPads and so on. That introduces a certain type of selection bias, because older patients don't have access to this technology, but hopefully over the years that will change.
We've also moved to an automated internet-based system, but I think the key point is that there's not going to be one patient-reported outcome measure that we as a community develop that's going to answer all the questions.
That's right, yes. Any other points? Jens? From Copenhagen?
Has anybody looked into cultural differences of these questionnaires? So can they just be transferred from Europe to United States, from Scandinavia to Japan?
Do you have any comment?
That would probably be one of the goals, as one of the plans going forward is probably to see if can we just use a standard one. But I'd imagine there's a lot of variability. Even within your patient population, we see people from all over, and we don't handle things the same way. So that would be important.
It's not only cultural differences, but also males, females, young, old. And a lot of the publications we've seen have tended to lump all patients together, and you can't really do that. You've got to look at the different subgroups.
So a lot of the validated scales do come in multiple languages and validated in all of the languages. We haven't done a formal study to look at cultural differences, but just in Canada, we're implementing in Toronto and in Montreal, and we noticed that you can't just do straight translation. It's, the language is a little bit different when you are doing the translation, and so there are, slight differences. But yeah.
That's right. When I tried to use the OOG questionnaire in the United States, the first thing my psychologist said, or my patient psychologist said, was, the patients don't drink tea in California, so we had to had to change that. One of the things we had to change, yeah. Yes, Andrea, there's somebody who wants to speak here.
So one thing that we touched upon a little bit in our previous section, the doctor-reported outcomes, was on data security and data housing. And if we go on to do patient-reported outcomes for multi-sites and sharing all this data, this is just a question I want to pose to all the other people who are tackling the PROs. How do you think that we can go about doing data housing and data sharing and then keeping all of that anonymous?
Right. We need to respect patient confidentiality. We also need to respect provider, doctor confidentiality. We don't want one hospital to look at another hospital and to say, for any reason. But it's useful for an individual department to compare their own performance with everybody else's, but with everybody else's data merged. One of the problems at UCSF is that they're not very happy with UCSF data housed in a server outside the university premises in San Diego. What if that breaks down or they don't have a good backup or something? And so the UCSF would like to have a module housed within UCSF to run this project. There's all sorts of legal issues and other things that I would never have thought of till this project came into being.
So we're currently looking at that in Canada, and so the patient-reported outcome systems have to stay within the local institutions because of they're the custodian of the data. But we're looking at, can you pull out a central research set of data and put that on a central cloud? So de-identifying all that data. So you definitely do need to have your local instances of your DRO and your PRO, but be able to have some sort of pull, and that's where your standardization of data comes into play. So you can customize per local site, but you should be able to pull the standards set together that's de-identified.
That's very good. Yep,
we use
3 or 4 minutes left.
We use a software called REDCap, and the reason we selected it was because it's internationally available in all local major universities with that idea, and the future communication and transference of data will be simple and easy.
Yep. So before we finish, how many of you are actually measuring patient-reported outcomes in your clinical work in any sort of formal way, either on paper or on computer, whatever? One. And how have you found the experience? Has it helped you at all, or have you? Has it changed your practice in any kind of way? It's changed what I say to patients and how I say things to patients. What about yourself, Tara? You've been doing this a long time.
Well, we're sort of doing it more in a research context, like answering certain questions. For example, stress was brought up. One of the things that we've looked at, I mean, this is a related topic, and some of the ideas might be helpful, is sort of how patients handle the initial diagnosis of uveal melanoma. And we've used questionnaires, and some of the initial data suggests that in order for patients to get through this, over the months, as we do send out repeat questionnaires, they need one of the strongest things people get through this have a strong support network. So I think for us, it seems like we need to provide a lot more than what we're normally doing. So we need to have counselors and psychologists, and unfortunately, those things they cost money, and they're resource intensive at different institutions. So it's actually, I think we need to figure out how we're going to help patients and supply this, because we don't have it naturally in our ophthalmic infrastructure. So I think that's sort of what we're seeing.
Yeah. In Liverpool, we're very lucky to have Laura Hope Stone, and in UCSF, now we encourage all our patients to see Jamie Cohen, a health psychologist there, and we're getting very good feedback. So it's one thing you can do that would really improve patient satisfaction, and is to encourage them to get this support, even if they don't know that they need it. I think our time's up now. Thank you very much. Thank you.
Thank you for this. Thank you very much for having me.